Thank you very much, everyone, and welcome to the PharmAla webinar on this Wednesday, April the 10th. We're here to talk about third-party insurance and reimbursement of the above. I'm joined today by Rev Darda and Jock Lovely from Cena Life. Thank you guys so much for doing this, for coming on, for talking about this, I think, pretty exciting topic. I don't know if other people's eyes sort of glaze over when you start talking about insurance, but it's it's a critical part of the healthcare system, and I think that we especially in the industry, we don't talk about it enough. So I'm glad we have an opportunity to do so. Maybe just to start, Rev, can I get you to start and just introduce yourself a little bit?
For sure. Thanks so much, Nick. I really appreciate the opportunity to come today. My background is in healthcare. I'm a registered nurse and have been practicing in Alberta for 30 some years. But in that time frame, I've really come to appreciate all the players in the ecosystem. And today I'm excited to chat more about how important third-party insurance coverage is. But really, my passion over the last 2 years has been in the mental health service field. And I founded and started Cena Life a couple of years ago, just over 2 years. And in that, I've been exploring not only how I can better connect those pieces of the ecosystem, but really how I can provide equitable access to those in need with services and treatments that are really innovative, and it's been a really long time since they've been able to be on the forefront of some options for individuals who are struggling with their mental health. So yeah, that's a bit about me, and I focus on an interdisciplinary team concept, and I'm really excited to be sharing my knowledge, as Alberta's been the first province to put in regulation and service standards and accreditation for psychedelic drug treatment. So I think these two things are really big steps for the province here to be sure we have safe, equitable, accessible care for those in their time of need. So thanks for having me.
Thanks for being here. Jock, do you want to introduce
Sure,
yourself?
I can jump in. So, hi everyone. My name is Jacques Lovely, and I am also a registered nurse. So, I've been nursing here in Alberta for over 25 years. Spent the bulk of my career here. And I'm the COO of Cena Life. Joined the company almost a year ago now, inspired by Rev's vision and her mission to support accessible, safe, efficient, effective care for a patient population that's been underserved for some time. And in my role, I focus really on two things. So my background, as far as training, has been to focus on knowledge utilization, research uptake. So how we incorporate new evidence into practice. It's something that I've studied and have been able to contribute. And then in addition to that, to really focus on system redesign. So how do we work with the stakeholders in what we affectionately call the ecosystem, so the healthcare ecosystem. So how do we work with those stakeholders to tackle the challenges, to evolve healthcare, and to ensure that here in Canada, it's sustainable, affordable, accessible. So that's a little bit about me, my role with Cena, and what I bring to the table and will bring to the conversation.
Great, thanks so much. Well, look, first of all, I mean, maybe let's set the table. Just as a housekeeping item, usually the way this works is we're going to talk for about half an hour, and then we're going to give you guys an opportunity to ask questions. There's always a couple of interesting questions. When we get to the Q&A, just write your questions in the chat, and our friend Conway will read them out for us, and we'll just take them as they come. We like to be sort of organic and really field questions on these webinars. But in the meantime, first, let's start with this. I mean, when we talk about third-party insurers, who do you guys think about? Like for the folks who may not be as familiar with the healthcare system, let's define what a third-party insurer is to begin with.
Sure. So maybe I'll jump in. And as I think it's a really important conversation because many people, especially in Canada, are unaware of kind of the ways that we fund, how we support, how our healthcare service is actually not only afforded to us, but I guess becomes part of the services that we have a right and a privilege to. And in that, I think a third-party insurance group is in place to fill a gap. And right now, we have public health services that are funded by Canadians across the country. And in that, they identify a certain set of services, not only by regulated or registered professionals like our physicians, but what we mostly think of is those acute care services that live in our hospitals, some of those bricks and mortar, really important at your time of need. So I think it's important, first of all, to say that there are coverages and services in Canada that are funded fully and we have full access to. But actually, there's several and significantly more services that don't have any funding. And this is where a third-party insurance group, and there's many to choose from, which I think is an important thing to identify too, that they would step in and they would help try to fill that gap. And that's through various ways. But really in this context, we're talking about them through agreements that you may have in an employment relationship that allows you to get and access those benefits as individuals who are seeking to help fill that gap, and they can pay on a monthly basis for programs specifically that would fill those gaps in services that are important to that individual and then help them maintain their health and wellness. So I would say that's really what a third-party insurance company is for, the role that they play in our system. But really, we have been dealing with, I think, in my whole career, many different types of services that have many different paying systems, so public and private.
Yeah, and look, I think really important to note, like when it comes to mental health care, unfortunately, the public system is definitely lacking. I mean, for you mentioned acute care. I think we're all familiar with sort of going to the emergency room. You break a leg, the public system is there for that. If you have long-term chronic conditions, I mean, there are sort of quasi-public institutions that sometimes fall into the realm of third-party insurers, but mental health care is not a core competency of our public healthcare system, I think, in many ways, right?
So maybe I can jump in on that because picking up on what Rev has said, lots of people as Canadians have a sense that part of the fabric of being Canadian is that healthcare is free. It's how we're viewed around the world as one of those great nations where healthcare is free. And in this sense of urgency or emergency, as you've put it, healthcare access is free, although the ambulance that took you there might not be. Right? And so there are component parts that work around that acute care system that actually aren't free. And for a lot of people, this comes into consciousness when they think optometry or dentistry. In extreme cases, you can find some dentistry in the acute care system for those who can't access it elsewhere. Or if something happens to your eye, then you. But actually, the main components of dentistry and optometry are outside of the public healthcare system. And as you've pointed out, that is the same for mental health. Mental health support does exist inside of acute care. If you are having an extreme exacerbation of your mental health, then you would end up going in ambulance and having a stay in a hospital. But actually, for the most part, supports for mental health exist in community and are paid for, as Rev pointed out, either out of pocket or through an arrangement through your employer or something you've accessed individually through a third-party insurer. And also because we live in an environment where so much of our benefits are supplied through our employer, we still sort of think about those community services as being free, even though they're actually being paid through a third-party insurer. Now, when it becomes really clear to everyone that something isn't free is when your benefits don't cover it. And really, that's what we're here to talk about today. So what happens when care is advancing and policy inside of either the public healthcare system or a third-party insurer hasn't kept up? And how do we work with our partners in the ecosystem to then move either existing policy or programming or arrangements forward so that the care that is now available has emerged has evidence to support it, actually is supported either publicly through third party or is at least at minimally made accessible because it's affordable
Yeah.
when you have to pay
And
out
look,
of pocket.
I can, yeah, like I can tell you this. So we now do something on the order of 10 special access program requests for MDMA every month, something like that. I mean, it's a little bit more, a little bit less, but consistently, the biggest sort of question mark for both the patients and the prescribers is, can this be paid for? By what insurance, like depending on the province, what insurance company, and with these types of treatments, they are new. It's a different modality of care, drug-assisted therapy, not something that we are very used to. And so, there's different components to that. There's the monitoring, there's the therapy, there's the drug costs. And all of these in the broader context can be covered, and province by province, different agencies sort of cover in different ways. But from my perspective, I think what Alberta Blue Cross announced is the most cohesive sort of policy in this regard that we've seen in Canada so far. Like, would you agree? Because I think that they've really established like a very, very clear guideline.
Yeah, I would say I'm super excited. Like when I heard and when this came forward, it's a game changer. And the reason I say that is because we can incrementally, which I think is occurring here, enhance the programs, understand what those needs are based on the demand. But I think this is a step into a real change, a real focus on how do we cover those component parts in a more cohesive way. And I also just want to say that Alberta, having licensing, regulation standards, and accreditation, and now having a component where it fills that gap that isn't covered by the public system, we are set up for success to be able to ensure that as we deliver our programming, that we can, I would say, abide by the evidence, but be flexible enough to ensure that we're supporting some of these program enhancement and changes that we've seen recently here in the province. So I am very excited, and as a business owner and as a clinician, I'm also examining how do I make sure that this fits, because sometimes it is challenging when you have a program enhancement and it isn't aligned with some of the operational ways that people do their work. And I think that all goes back to how do we optimize our services? How are we making sure that we never compromise safety and quality in optimizing the service? So it's given me really an excitement and incentive to say, oh, wow, look, here's a program that actually is covering this currently. And right now I'm speaking of ketamine-assisted therapy because, to your point, Nick, the special access program and the medicine around that still has a little bit of time, hopefully not that long,
of course,
so that we can have an opportunity to have that covered as well. So it's very exciting.
I think to add to that, Rev, what I would say is, Nick, for the most part, when programming is developed, when a clinical pathway is developed, there are sort of four influences that are at play that are shaping what actually results, right? So how patients access care. So all of it starts from the evidence, right? Things need to be evidence aligned, but when care is studied, remember in those trials, variables that might be influencing they're trying to edit them out. And so they can really study what is at play here, what is supporting these outcomes. And often in a clinical trial, there isn't an early understanding of, can we actually operationalize and afford to deliver this? We're actually really right now just focusing on the evidence that tells us that it works. And so we throw in sort of at all cost, right, to get the evidence that actually supports. But always, once that evidence is there, operational leaders in healthcare or across the ecosystem are sort of in that position of saying, okay, but then how can we actually deliver this? And that's where more influences come into play. So one of the really important sort of, I think, strong arm type influences is existing policy. So what policy right now influences this type of care, influences how it can be paid for, influences who can access it, who can deliver it under what scope of practice. So all of that existing policy usually just gets worked around and says, this is based on policy, this is how we can do this. It has to be delivered by this clinician, even though they're more expensive, right? That's the only way we can get paid for it, et cetera. So that policy piece is really important. And then in addition to that, when people are designing clinical programming, there are two other influences that are there. One is provider preference, and that might be things like, I only want to see this many patients in a day, or I only want to provide care in this window of time, or I need a mix of patients because they're really hard to serve patients. I need a break from those. Or I can only see so many of those in a day. So it's important to raise that that is an influence that actually shapes access and what gets provided. And then in addition to that, and I really want to emphasize this one because I would say that all efforts are made in designing programming to really keep patient preference and patient impact in mind, down to how long do they have to be here and how much is parking going to cost them if they're doing that. So we actually think through every aspect of how many visits do they have to have? Could any of those be virtual, which is a whole new world now after the pandemic. So all four of those things are really influencing what programming actually gets developed and offered. And to Rev's point in your earlier question, when we were looking at psychedelic-assisted therapy and knowing that it is out of pocket, there always was some coverage. So there was potentially coverage for molecule or medicine under people's drug plans, and there was some coverage for therapy under their existing therapy program or plan. But when you design a program like psychedelic-assisted psychotherapy, it involves an interdisciplinary team. So you have a psychiatrist, you have nurses, you have therapists, you have unregulated supports, all that are contributing, and keeping in mind that most of them have been put into the plan all of them really have been put into the plan to make the delivery best possible outcome, to make the service model as efficient as possible, so therefore affordable and accessible, to ensure that it's high quality, to ensure that it's safe, and to ensure that it actually adheres to the evidence. But when you're designing that program and you're thinking about the policy around it, only those small parts can be paid for, so everything else has to be out of pocket. So what's so great about what's happened now with this coverage is it actually takes into consideration what happens by the other clinicians around those two, the molecule and the therapy, to say, we can also cover those components because we know in your program of care they're there when they happen, on the day of therapy. And so that is really proactive and a game changer, because it actually means what the nurse is contributing in that program of care can be covered.
It's included, of course.
And in this case, when there is a molecule that's being administered that needs to be physiologically monitored, the therapist doesn't do that. And so it acknowledges that that is a core component and can now be covered. And it sounds so simple, but it didn't exist before 4 weeks ago, anywhere in the country.
3 weeks ago. Look, I think to your point, that is, I think very much to Alberta Blue Cross's sort of credit, that they clearly looked at, like, what does psychedelic assisted therapy look like here in the real world. They clearly spoke to some practitioners, and they designed their policy approach based on the reality. Because I 100% take your point, like, clinical trials are not a good predictor for how therapy is delivered or treatments are delivered in the real world. I mean, even just the little things, I can tell you with 100% certainty that clinical trial practitioner preference is for synthetic molecule. Whatever you're studying, everyone wants synthetic molecule because it's very, very easy. You have like a very standardized dose. Everything's like sort of, there's a nice box around it. Patient preference with our kinds of molecules, with psychedelic molecules, I mean, if you're looking at sort of naturally derived molecules like psilocybin, you can get synthetic molecule. We sell that. No patient wants that. They all want natural, right? Like, there's strong patient preference. And so anyways, but all that to say, very much to Alberta Blue Cross's credit that they clearly thought this through in a very, very deep and cohesive way. So I mean, you guys are based in Alberta. Were you consulted? Was there some conversation? How much can you say?
Well, maybe I'll jump in because I think advocacy is where I'd like to start. So,
Yeah.
being in Alberta, being a part of our healthcare ecosystem for my whole career and continue to be for part of my whole career, is founded in advocacy and advocacy for clients. And so I want to just say that no matter what relationship, what conversation you have, if your focus is around advocacy, what you can do is you can bring information forward because you are a practicing clinician in the ecosystem. So I think that's what I try to do in all of my interactions. And I have more success in some of those than others to be able to identify and share information. But as I'm sharing that information, I think it's really important to know that it isn't one-sided and it shouldn't be to the benefit only of the individual who's advocating for changes that may make their service delivery model, or as Jacques said, their team kind of better represented, better funded. That's never the intent. So I do think there's a huge role for advocacy. I think we have to still do it as operational services continue to evolve, because we're not in that the petri dish, the clinical trial world.
Yeah.
And based on that, I think what we did is we offered information. We were asked and offered information about what is the real world experience. So actually that's not hard to do, and we do it with tons and tons of people all the time. We're just open, and then if they'd like to hear a bit about what program we are offering, how we're evolving it, what that involves, why we're including interdisciplinary teams, that's kind of the approach that we've taken and we will continue to take. And then I think the other thing's really important is to connect yourself to know where the evidence is, how it's unfolding, but really within broader practice networks. We are not islands unto ourselves. There are many groups, whether that's private practice psychology groups, whether that's other medical teams, whether that's other medical professionals. We have to stay connected as well, because if we're evolving and advocating and sharing that, we're not connected, we're missing key pieces. So two things that we've done and we continue to do is we connect with others on the ground to understand a bit about what they're doing in their service model, how we're looking at that to meet those goals that Jacques has alluded to. Safety is number one, never compromise it. Quality, efficiency, and effectiveness. And then the second is to be willing to share. Anytime anyone asks us, we try to contribute in a way that's easy, not too clinical, and then share that and be open for questions.
Yeah.
I think it's important to sort of say we always start with the principle. So first, we're making no assumptions that we were the only people who were talking with, right, about this.
Of course.
So
no, I'm sure they sort of consulted
incredibly
widely. Yeah.
Incredibly grateful that we had a bit of space to share what we know. And whenever we approach this sort of scenario, we really come from the understanding that everyone in the ecosystem is trying to do the best that they can, and that they want to help the population that they're responsible in the way that they can. And so when new evidence emerges, new practice emerges, everyone is in a bit of a place of, who are the experts in this? What are the things we should be considering? And so Rev and I've spent our whole careers here in Alberta, trying to advocate for advancing care and advancing systems and policies and that sort of thing. And so that being the case, it was, there are ways you can deliver care that are really expensive, right? So in a private world, there are models where you maximize profit in the design of your service, because you don't want to deliver a lot of it, but if you can deliver some of it to the people who can afford it, you can make a higher profit. And think of any high-end brand, that's what it's for. And but that's not actually what we do in healthcare. What we do in healthcare is we try to create as much supply of the highest quality with patient safety that we actually can. And that means we have to really dig into what are the scopes of practice of everyone who could be contributing. Do the ones who cost more really have to do those parts, or could they be done by someone else? And so our first principle was to come in and say, let's share as much information as we can, not just about what the evidence says, but what you should consider when people are presenting programming to you around who could do what. and how it might be offered to still be high quality, be safe, but actually be more affordable. So
Yeah.
not taking so much out of your program so that there's
Yes.
less to go around, and actually so that you can reach more people who need this, because we know in this particular case there's a huge population who's struggling with
Yeah.
mental health. So there actually has to be a lot to go around.
Yeah.
And so
Yeah.
so we considered there all of those perspectives and present in a way, no matter who we're speaking to, of here's the sort of full gamut of considerations, right? And here's things that you need to know in that full gamut of considerations. Here's perspectives from individual stakeholder groups and what's great about what they're bringing to the table, what you could probably challenge about what they're bringing to the table, because we know turf protection and
Yeah.
a sense of distrust amongst interdisciplinary teams are things you have to work on in order for that sort of highly optimized, high functioning team to really make their contribution. So we present always in that sort of fulsome way of all the things that you can consider. And then we go one more step to say, when we think from your lens, right, as a third party insurer, you provide a service to organizations to keep their people well. And we understood from those conversations that typically the organizations themselves have to be asking for something in order for the third party insurers to develop it for them. It's not often that third party insurers are ahead of the customers they serve to say, here's what you're going to need, so we're going to design it before you need it.
Yeah.
But
I mean, look, to be fair, I think the Alberta government also was ahead of the curve when they designed the regulations.
That's
So
right.
I do think that they all like the jurisdiction of Alberta is sort of ahead on two fronts now. Ahead on regulating inside the province, the concept of psychedelic therapy, who can practice in this fashion, what are sort of the ground rules around it, which I think still to this day, Alberta, those regs are over a year old. I think Alberta is still the only province that has regulations.
That's
And
right.
now, sort of a fulsome major third-party insurance coverage. I think those two are related, right? Like it gives the insurer comfort that things are being done properly and according to a set of rules. It's not just a black box. And at the
Yeah.
same time, the government knows that, these rules have led to hopefully some great patient outcomes.
And it's definitely symbiotic. And I guess I just want to make that point of to give credit where credit is deserved, right? So even though most often, third party insurance companies would be just being responsive to what they're being asked for, there are leaders in the world who are thinking about where the industries are going, where the people they serve's needs are going to take shape going forward, and are being forward thinking about how they're going to meet those needs. And I'm purposely saying this because I'm implying that that's what's happening,
Yeah, for
in this
sure.
case. And I think your point of saying, were they further reassured because they exist in the province where regulation is already taking shape and we see ministerially that they're already being forward thinking? The reality for all of us is that we have a mental health epidemic on our hands. And when it comes to those who are suffering the most, who are being underserved by traditional treatment options, then there's an incredible need there, and that need is growing. And then when we go beyond just the hard to serve, so those people who are treatment resistant, to people with initial diagnoses, there are a lot of people in this population who, when given the choice between traditional treatment, so going on an antidepressant, or trying this approach, would prefer this, and patient preference matters in their relationship with their clinician. So what happens now is that those populations are granted better access because a third party insurer is being very forward thinking, and a ministry is being very forward thinking.
Yeah. Yeah. Well, look, I say this constantly, both within PsyCan, our trade association. So we have a trade association for psychedelic medicine companies, whether they're clinic operators or manufacturers like ourselves or research companies. I constantly drive this point in the association and also just within the company that you have to stay focused on patients. Like ultimately, this is all about the patients. And so the moment that you take your eye off that ball, you start to drift away from the outcomes that you want to get to. And to your point, sort of reducing cost, maximizing availability, all that serves towards the good of the patient. And frankly, I think a bunch of people are sort of tired of me banging on that patient drum, but the moment we stop banging on about it, that's when we start to drift. So yeah, it's hugely important and really, really nice to see. I don't know if anybody would have expected Alberta to be the sort of the market leader on this, but definitely like way out ahead in front. Really impressive stuff.
I agree.
Well, look, guys, I'm going to say if there are any questions, we're gonna start taking questions. I know there's one, but before I have a little bit of a surprise that we're gonna share on behalf of PharmAla. I hope you'll indulge me. It'll only take a minute. But in terms of trying to be leaders in our space, so currently we're the only company that provides MDMA to patients through the Special Access Program. And one of the things that we've heard for ages and ages and ages is, I'm a prescriber. I really want to do more of this. It's cumbersome. I don't know what I'm doing. How do I do it? So PharmAla, in an effort to serve some of our sort of customers, the prescribers, has actually created a prescribers portal to assist in filling out SAP applications, learning more about MDMA-assisted therapy, the drug product we produce, all that fun stuff. This is all behind a login wall, so it is for prescribers only. If you're not a prescriber and you don't have a license, you have to provide your license to us to get access to this. Those are the terms of the Health Canada regulations that we operate under. But for those of you who are prescribers and want to sort of engage in doing more MDMA-assisted therapy treatments through SAP, a great new tool. It's available at sap.pharmala.ca. And it is now as of this moment, now in open beta. So please come on by and take a look. And with that, maybe
Awesome.
I will.
Congratulations.
Thank you. Listen, again, I just hope that it helps, I know a lot of doctors and I know a lot of therapists now. I didn't know as many before I started working at PharmAla, but know a lot of therapists now. And the one thing that is like this constancy, especially in our healthcare system, is everyone is just so busy. Like everyone is just like, especially post-COVID, everyone has just run into the ground. And so if we can do anything to just make their lives like a little bit easier, I think that is gonna, again, maximize access, maximize outcomes. That's the goal.
Amazing. I want to say that we've had special access program applications, and you're right. It's hard to find time, but I think when you start to share and you learn from each other, that gets easier. And then definitely having a tool like that allows increased access, because there's so much that if that prescriber doesn't have a team behind them or potentially isn't, freed up, has to do this in the weekends or the evenings, it limits access. So I just want to say thank you. That's towards increasing access just in that small way that allows us to, and I wouldn't use the term standardized, but consistent and streamline some of the ways that we're doing that. So I'm hoping that there's more and more applications as we go forward, which also would demonstrate to Health Canada that this is really something, not only prescribers, but the clients that they're serving, as we've just alluded to, is their choice. So thanks so much, Nick.
No, listen, thank you. And not only that it's the patient choice. The other great thing about SAP is it allows us to gather data and allows us to take that data, real world evidence, go back to Health Canada and say, no, look, this is an effective treatment. It's really helping people. It's safe, right? As long as the data supports that. I personally am convinced. I have no doubt that that's what the data will say. Reasonable people can disagree, but it allows us to gather data in here in the real world where things are messy. We talked about the difference between clinical trials where you cut out every single variable except the ones of efficacy and safety. I think that this is a great opportunity to sort of gather real world evidence and then utilize that with regulators. And I've always argued, both from when I worked in government and now outside of government, that the governments need to take more of a real world evidence approach when they regulate healthcare. Lots of things, when you experiment, lots of things look great, and then when you get into the real world, they don't quite live up to our hopeful expectations. Okay, well, with that, why don't we get into some Q&A? Because I know that we have a couple. Conway, do you want to read out the first question?
Absolutely. So this one isn't directed to anyone. Anyone, please feel free to jump in. So Hiso is wondering if we have any insight on the following statement. Plan members can also claim associated services delivered in conjunction with psychedelic therapy, such as assessment, drug administration, and monitoring, that is, performed on the same day as the therapy. Is this a requirement to have the psychotherapy component on the day of psychedelic drug administration?
Yeah, so I've had opportunity to sit with a manager of the program to dig into every sentence, right? And what does that actually mean? And it does exactly mean that. So when you think about assessment, administration, and monitoring, those are the roles that typically the RN would play. And in order for them to be covered, the way that the program is designed, they have to happen on the day of therapy. But that is possible, right? So it influences, just like I said, policy always influences your program design, but that actually is what it means.
Cool. Well, I certainly have nothing more to add. Why don't we move on to the next question?
Awesome. So Sarah's wondering, would like to ask, what services or components of the psychedelic-assisted therapy intervention are covered through the Alberta Blue Cross insurance?
Rev, Jacques? I think you guys are closer to this than me.
Yeah, for sure. Well, I'll just start off by there's been no change to the therapy coverage. So the underpinning of psychedelic-assisted therapy is therapy, and there's been no change to that. So based on an individual plan, that they have a certain limit to be able to claim to offset and support those costs. Right now, because of the licensing, that has to be through a regulated or registered provider. So I'm not too sure if people on the call know, but we have so many experienced and skilled and great therapists, but not all of them have always fallen under a regulatory body. In Alberta, actually, this is another first, they're moving all of those counselors and non-regulated therapists under the umbrella of a college or a regulated body. So that's great. So now the workforce is able to participate based on the licensing. But just to start off and recap, is therapy is still covered, always covered. And then I think, as Jacques said, the medication administration monitoring piece often occurs by another regulated health professional. And that other regulated health professional could be a physician, could be an RN, could be a nurse practitioner. We take a look at scope of practice and identify what that component is. So that is the medical professional as the skills, training, scope of practice to be able to provide medication administration, monitoring, and assessment. And so now that includes other members of the team who've normally the cost or the fee for what they provide or the service they provide has not been covered. And now that can be incorporated into the submissions of the invoices for the clients that are seeking those coverage opportunities.
Cool. Yeah, look, I will say, obviously I'm not a practitioner, we don't operate any clinics, but I was struck by how the various elements of the psychedelic assisted therapy are broken down basically by buckets. And I think that is, to my mind, again, reasonable people can disagree, but to my mind, that is where this approach is different from other approaches in other provinces, where you have somebody who's really thought through everything and just assigned the right sort of pieces to the right buckets in people's insurance plans. And of course, like anything else, it's not perfect. I'm sure that there's people who will say like you need more here, or you need less here, etc. But a great start to have an insurer who's sort of really thought this through.
And it really sets a precedent for others to follow suit, and we hope to take it even further. And so, things like overall caps for psychotherapy or daily caps for amounts that can be charged, those things still exist. And so therefore will limit how much can be incorporated, even in a more comprehensive or an adjusted policy like this one. But always in the back of my mind is this notion: third-party insurers exist in order to serve the organizations who have asked them to keep their people well and at work. And when they think about what it is that they need to offer those organizations to keep their people well and at work, we know that there is a lot of burnout. We know that there is a lot of stress leave. We know that there are initial diagnoses of depression and anxiety and PTSD, et cetera, that are all associated with psychotherapy and with psychedelics as potential treatment options. So there's still a lot of room for third-party insurers to consider the impact they can have for the organizations to keep their people well and at work, to expand on what's already been done by Alberta Blue Cross. So I think for us, it really is about having the first mover and ideally that second follower, or the first follower, sorry, that will come now and say, that's good, but we can do better, and take it even further.
Yeah, absolutely. And I can say, I think we're going to get a question about this, but I can say on our behalf, like on behalf of PsyCan, on behalf of PharmAla, we're going to be hard at work going to other provinces that maybe where we have I'm based in Ontario, we have WSIB here. I know that they have thought about it. I don't think they have a clearly defined policy yet. Great impetus for us to go to them and say, hey, let's share what we know. Let's share what has happened in Alberta, because we think this is a great best practice, and let's see if we can define a clear position for you guys too.
Absolutely. Well,
Yeah.
and we would encourage you, when you do that, to keep in mind that they really are all there trying to do the very best that they can.
Yeah, of
And
course.
that the more that you can help them to think outside the box, and the more that you can help them to quantify the impact that these changes can make, the more empowered they actually are to pioneer or to lead, break ground in the particular area you're asking for help in.
For sure. Okay, we got two more questions. We might have more, but let's get into the last two here.
Absolutely. So staying on this topic, are the respective psychotherapy colleges aware of this change? Historically, they have been cautious about practitioners administering psychotherapy while the clients are in an altered state of consciousness, especially when it comes to ketamine.
Oh, look, I can say on my behalf, we've had I wouldn't say it's a long time relationship, but we have a relationship with Ontario Psychological Association, and they are 100% watching this very, very closely. I think lots of very, very interested psychologists. Obviously, most psychologists do not have prescribing powers, so to again, not to keep banging on about Alberta, but very, very nice to have clear regulations about who can administer therapy and who's responsible for what, which Ontario does not yet have. But I will say that from my perspective, looking at it in two different continents, here in Canada, of course, and then in Australia, there is a very, very high degree of interest and engagement, more so than you would have seen, I think, in other like new drug treatments, because it's a general awareness of psychedelics as a category rather than one drug. It's not just ketamine, it's not just MDMA, it's this whole new modality of care. But Rev, Jacques, what do you think?
Well, and there's so much to jump in here with, Rev, and so we can tag team on this one probably, but there's really two categories to think through in your answer, and the first is to think through each individual molecule and the journey that it creates. So often, in a ketamine experience, you don't actually see a patient interacting. You actually see them going into what we call inner space. So through the duration of the medication, they're actually quiet, they're not social, they're not interactive, they're actually having an experience inside their minds. Psilocybin has some variety of inner and interactive, and MDMA is very interactive. And so we would just say, you have to really gain familiarity with the experience the molecules generate in that context. And then the next thing, and maybe this is where Rev, you'll want to jump in, when we think about those who are specializing in, say, a substance use or abuse disorder, and how they're tapping into the use of psycholytic doses and psychedelic doses to actually help individuals who are struggling with those diagnoses. Just as an example, you actually see the sort of forerunners or front runners in these interventions, using both psycholytic and psychedelic. So definitely doing therapy with molecule at varying amounts to foster different ability for the patient to address fears or traumas. Some that are about just bringing sort of the edge down and allowing them to be more interactive, and others that are allowing them to go on a psychedelic journey. So there's a ton that we could talk about here, but I think that the bigger question is, where are the colleges going with this to support it? And we're seeing them pay attention to the evidence as well. So I'm sorry, I probably stole a lot of it, but I don't know if you want to add to that.
No, I think it's great. And you're right, there's practice already in place, depending on dosing, that has medicine and therapy combined. But I think we have to really define that, because as I think the question pointed out, are people in a dissociative state and you're trying to have therapy with them? Yeah, that's not actually what is going to help and create the best outcomes for that client in going through the program. And so I think, as Jacques was alluding to, really trying to define what does it mean when you're saying therapy on the same day. You have to start to get pretty operationally creative in the context of that for people to be able to access these benefits. And so if we've historically thought, you have therapy this day, you come in for medicine this day, you have therapy that day, we have to identify the components that we do within therapy, intention or integration, how that occurs within the span of the day, I'll say, and then what's client choice. You don't want to have people coming in, leaving, coming back, but potentially with some hybrid models, as Jacques said, the ability for client choice. We are actually adjusting our programming so that it can meet the needs of this coverage, sit within the evidence, and have really great outcomes, maintain those outcomes, which we identify, track, and monitor. So I haven't answered the question, but I think it is possible, and it's within the course of the day, even though sometimes we think, does that happen all in one appointment? So it's within the course of the day that gets set up. And then the ability to think about therapy as reimagining and re-envisioning your intention setting, really coming back to the place, and even doing your integration on the day of medicine, but it's actually in a timeline and a cadence that's supporting your previous medicine session. So that therapy that we talk about is really important, and we have been tasked now, based on that program enhancement, to take a look at how we're delivering our programming, which, again, back to my point, is exciting for me, because this is where we actually get real world, not only experience, but we create access in a way that's way different than what we talked about, that rigid and structured clinical trial.
Yeah, totally. Okay, last question, and we're gonna let everybody go. You guys have been great. Thank you so much for doing this and sharing all your knowledge with folks, both here and this is gonna get recorded, so it'll live on YouTube. One last question. Go ahead, Conway.
Towards access and folks working to their scopes of practice, are nurse practitioners included as prescribers for SAPs?
So actually, any medical professional with prescribing powers is able to submit a request for special access. Now, that doesn't mean that they're going to approve it. It is a case-by-case approval by Health Canada. But yes, if you are a nurse practitioner and you have prescribing powers, you absolutely can request a special access program application from Health Canada. And they're getting really good. They're getting back to people in like 48 hours. It's pretty impressive.
Really good. Yeah.
The joke I always make is like, the first one is impossible, the second one is hard, the 100th one is like no problem. Like, we know what we're doing, we know what to look for, it's all good, we can figure this out.
Right. And now with the portal, it's even that easy.
Now it's even easier. Exactly. Well, guys, look, thank you so much again. Wonderful conversation. Really, really appreciate you guys just being here and talking this through. Super excited about what's going on in your jurisdiction, and hopefully what's going to keep going on in others in the near future. So thanks again, and we'll talk again soon.
So much, Nick. Thanks, Conway, and everyone else. Talk soon.
Bye, guys.